Hello, I am Dr. Mohammed Douaim. I am Associate Professor of Prosthodontics and Faculty of Oral and Dental Medicine. Today we are going to talk about introduction in dental implants. We will have a lot of general idea on dental implants, and every point in dental implants that we will go discuss, it will be have a huge lecture. If you need this one, just text me or say that I need this part to be described, and it will be described for you for a video, and I will send to you or on my channel. Okay. Today we are going to talk about something, as we said, it's introduction for dental implants. In all days, dental implants, it's like a framework, and it's called subperiosteal. In some cases, we need to do subperiosteal today in 2023, but most of cases we are going for this one. This one is called root form dental implants. It's rated and it have surface treatment. If you have for the history of dental implants, we'll have that's the first one or first options for dental implants. As we know today, is innovated by Dr. Pennermark, and he have an experiment on some animals, and he found that some sort of criteria called osteointegrations. What mean of osteointegrations is direct construction and function contact between the titanium that you added in the bone and the bone itself, and it carry loading on it, and it will not be separated. It's contact and the bone integrated with the titanium, and the titanium integrated with the bone to be one structure. So if you have placed the titanium implants in the bone, it will have the deposit of bone on these implants and the surrounding bone. And the criteria for osteointegration must know fibrous tissue. If you have fibrous tissue, that you will have some sort of failure of dental implants. So you must have these issues. Okay, now we are going to talk about titanium dental implants or titanium alloy dental implants. It's root form as we see. Ordinarily, in any crown and bridge or prosthetic options, you will have reduced tooth, and you will have a crown on that tooth. Okay, and this tooth will have a root. It's the same options like implants with different shape and different criteria. So if you have this implants in the bone, and you have a reduced structure like here, so this one is the root, dental implant root, and this one is the abutment, and this one is the crown. It's the same. This one is reduced as normal crown issues. Okay. So if you find this, there is a root in the bone. There is abutment. This is called abutment. It's like the abutment tooth is reduced, as we said, as there is a finish line, and this one is underneath the gingiva. Okay, and the superstructure or the crown. This is for the simple one. And the abutment itself, like this one, is fixed with the implants with a screw inside the implants, and this one is cemented to the abutment. So we have three structures. First one is the implant itself, second one is the abutment, third one is the crown or superstructure. Okay, so this is a type of dental implants. There are a lot of type of dental implants. As we said, this is abutment, and this the root form. Sometimes abutment and root form is one piece. You cannot be separated, and this is called one-piece dental implants, and it's called two-piece dental implants. Nowadays, most of cases we use two pieces, as a one piece will go on for some issues for immediate loading, and we are talking about immediate loading after a while. Okay, let's see. If you have a patient like this, if you put the dental implants here in the bone, and then we are going to have the abutment, as we said, and it will be connected to the implant by a screw here inside and the crown. Okay. So as we have a lot of companies, the companies get the implant with different diameters like this one, and different lengths for the dental implants. This, as we said, this 3.7, 4.2, it's the same company, but the implants has different diameter and different lengths. Okay, As why we do this for different diameter and diameter lengths, as each case will have different bone types and different bone amount and different bone quality. So there is a change in the surface area and the surface for the dental implants for these issues. Okay. So how we insert the dental implant in the bone? This is the main questions what we said. As we said, how we make drilling or how we insert the implant in the bone. Okay, so to insert the implant in the bone, it's like any type of screw retained instruments. We'll have to drill in the bone and then we'll have to put the implants. And as the implant it has different diameter, as we said, we have 3.5, 4.7, 4, 5.7, 6. So we'll have these drills to add it. And we will see that it's color coding, and each implant has each drill, sorry, has some sort of diameters, as we said. These two diameters, the 2.5, the 2.8, 3.2, 3.6. So if we have implant with 3.5, so we're going to stop on that drill. If we will have implant 4.5, it will be here. So we have sequential drilling. We are going for, if we have 3.5, we're going for this one and this one and this one and this one. Then we'll put an implants. So the drilling, it will be much more lesser than the implants, and we'll have successive drills. Why we will have successive drills? It will not make a trauma to the bone, and we have good angulations. And if we have bad angulations, we can change the angulations and put the implants parallel to the root of the near tooth. And as we said that we have color coding for here for the drill itself, and we will have this one which is called depth marker for the depth of the implant. And as we said, we have the implants with different diameters and different lengths. So this one will be here 6 mil, this one will be 8, this one will be 10, this one will be 14, and over and over. How? So what we need, why we need this one, as we said, we have different types of bone and different amount of bone, and we know that it's vital structures. Like in the upper posterior we have a sinus, so we measure the length from the crest of the ridge to the sinus, and we remove 2 or 3 mils for safety, and we'll drilling. So if you have 6 milli or we have 16 milli for bone from the crest of the ridge to the sinus, so you can go for 14. If you have 12, we can go for 10 implants, and we have drilling to the marker what we have. And for the insertion, it will have a lot of techniques. We can make another presentation for it. Okay, we will have now this one is illustrating video. As we said, we make a drilling. It's a different sequential drill. Each drill will be much more diameter increase to add an implants, and we have a covering screw, and this one is called covering screw, and we have stitches, and then we left it for a time to have an osseointegration, direct bone contact, as we said. Then we open again and put this one is called gingiva former. That's the gingiva will heal to have a good emergence profile. Then we have the abutment screw, then we have the crown. This is a classic way. It's 2-type surgery. First one we have put an implants and close it with stitches, close the soft tissue stitches. Then we will go for open it and add gingival former for 1 week or 2 weeks, and then we are going, after 1 or 2 weeks, we are going for the impression material and impression techniques, then the prosthetic options. And as we said, we will discuss this for in brief, but if you need, we have a big lecture on each topic, as we said. So what is else? As we know and as we see that the implant is inserted in 3 dimensions. So the implant must be we must know the mesiodistal directions of it, apicocervical direction of it, and buccolingual. So the mesiodistal is from the implants to the nearest tooth will have 1.5 degree, as we see this 1.5 and this 1.5. Okay, So, but between two implants, we need 1.5 for this one and 1.5 for this one. So we are going for 3 milli. So between two implants, we are going for 3 milli. Between implant and tooth, we need 1.5 of bone. So if you have 6 milli between lower 6 and lower 5, so you will lift 1.5 from here and 1.5 from here, and you will add 3 implant with 3 in diameter. And this is just an example to show you that you must leave 1.5 from here and 1.5 from here. And if you don't leave 1.5 for each implant, this will go for bone resorption, and it will be less blood supply on it. Okay. What else? It's bacolingual. Yes, as we said that the implant needs 3 dimensions: mesiodistal between tooth, bacolingual between buccal plate of bone and lingual plate of bone, and we need to know cervical, as in any object in the world will have the 3 dimensions or 3D. The 3 dimensions for implants, as we said, bacolingual, mesiodistal, and cervical. So what we'll do, we'll have 2 milli from 1 to 2 milli, we average 1.5 from buccal and 1.5 from lingual, and we will lift it. So if it's 8 milli, so we have 1.5 here, 1.5 here, so we can add 6 milli. Choosing of dental implants, diameter and length, it can go for, as we said, for one lecture also. And we can go for bucklinger with the cross section X-ray, which is called CBCT or CT, normal CT. So you need this type of X-ray to know the buckling. Okay, what about epicervical? Epicervical, we need to have 2 milli from cement to enamel junction. As if you go the depth of the implant will be too much in. This means that you will have long abutments and you can go for pockets. And if you go on the cement to enamel junction itself, so this means that the abutments will be appear from the gingiva and it will have metal display. Okay, as we said, this is the classic way that you have opened the flap and put on dental implants, put a screw like the video what we see, and then screw the mucosa. Okay, and then after 2 to 6 months, about according to the bone, according to the maxilla or mandible, according to the quality of the bone, the procedures that you do, we open it again and add like sort of healing cooler or gingival former to get the type of the gingiva or the shape of the gingiva. Okay, then you have take an impression, and after impression you have a prosthetic. The impression can be conventional or digital. This another issue we can discuss after that. Okay, so the classic way is 2 steps. First step, you put in implants and you sutures, then you open after a while and you add a gingival former. This is called a two stages surgery. It's another way to have one stage surgery, that you have an implants and put the gingival former and stitch on the gingival former. So you will see the implants in the same day of the surgery and you will not need to open it again after a while. So there is 2 types of surgeries. It's 2-stage surgery and 1-stage surgery of dental implants. This is called the classification of implant procedure for the type of surgery. 1 stage, as we said, we're going for gingival former in the same surgery, and we go 2 stages, we're going for covering screw for the first one, and then we open it and make a gingival former. Okay, normally we get that we get a patient who extracted the tooth from a wire, and we make a drilling. We open the mucosa and make a drilling as normal, and we have successive drill as we said, and put an implants and close it at two stages, or do the gingival former itself in the same one, and we called one surgery. This is called delay implantations, as the tooth is not here, the tooth is extracted from a while. So after extraction of the tooth, you will put an implants after a while. So it is called delay implantation. What about to have a root? Can we extract the tooth and put the implant in the socket, as we said before? Yes, it can be. It's called immediate implantation, and we need to do the implants in the same day, or after extraction the tooth. You will add the implant, and it's called immediate implantation. If you extract the tooth and you will wait for 6 weeks until the implant is added. Okay, and it's called early implantation. So if you have a root, you can remove it and put an implant, and it's called immediate implantation. But some terms that must be added in your mind. The first one, that the socket must have a bone underneath or below the socket, as the implant will be engaged in that bone. Okay, and the implant, when engaged in that bone, it's called native bone, and this one is good for the immediate implantation. Some people said that why we don't make an implants are engaged in the bundle bone or the bone around the socket, as we have two misfavor for that, or two not favor options for that. The first one is the bundle bone will be resorbed after a while, so the implant will be engaged to the bone that will be resorbed, as this bone, the bundle bone, as we know that it consists of insertion for the horizontal ligament for the root, so it will be resorbed and the implant will be floating for some time. So we need to engage the bone underneath the root. Okay, second one, if you have these implants and you have a socket, this socket in anterior area, like an example, the diameter for this anterior for the socket, it's too large, and if you do add an implant, you need to make it more large, so the implant will be added here for 7 milli or something like that, or 6 milli, so it will not be good in options. And the second one, as we know, there is some sort of terms called emergency profile, that the tooth will be smaller from the cervical and larger from the incisal. It will be fan shape or it will be triangle in shape. So if you had an implant here, it's large, so it will be square in shape, and it's not a good in our prosthetic options and prosthetic treatment plan. So we need to make an implant engaged in the 2 or 3 milli of the root. So if you don't have this 2 or 3 milli underneath the root, like if you have root with 8 milli, and you have inferior wall of the nasal cavity, from the crest of the ridge is about 9, so you only have 1 milli, so it's forbidden to make this immediate implantation. So immediate implantations can be, yes, but with some precautions or some terms, like you must need a bone underneath the socket to be engaged with the implants. And we have a lot of terms, but this is the main one we can discuss afterward. Now we are going to see this video. We extract it. We open this one. And we close it, and after a while we open again, and this the immediate implantation with 2 surgeries procedure. Sometimes we can make immediate implantation with 1 stage surgery. Okay, okay, so now we have delayed implantation, or delay implant placement, or immediate implant placement according to the case. Okay, what about the abutments? What about the loading? What about the crown? Can I remove the tooth and put an implants and make it and do the crown itself? Yes, it's called immediate loading. So we can make immediate implantation with immediate loading. And what about delayed loading? Can we do this? Yes, we can do delay loading after a while. As we said, it's a classic way that we have after that. So we can make some sort of classification for immediate loading. Delay loading is after 4 or 6 months, and immediate loading with the same time we put an implant. So we have a lot of classifications, and these classifications can be classified like implanted procedure, one stage, two stage, immediate placement, delay placement, after extraction the root and make it like healed, and then add an implant, or the same root extracted and put an implant in the same time. This one for implant loading, it's called delay loading or immediate loading. As we see, we can make the implant itself and put the abutment and put the crown itself, and this one is called immediate, and the delay one is put an implants and left it for 4 or 6 months or 2 months according to the case and do this one. So we can make a complicated classification also, and we make a lot of mix. You can have delay placement one stage and delay loading. We can have delay placement of one stage and immediate loading. You have a lot of options, but the immediate loading is always one stage. Okay. As we have an anatomy and we have like of sort of pattern of resorption, as we see, we have a pattern of resorption for the maxilla and the mandible. The maxilla is have a buccal plate of bone resorption. After you extract the tooth, you will have like some sort of recession for the bone for the palatal side. From the lingual, we have some sort of resorption from the lingual side. So as we said, after a while of extraction, and you will see that in complete denture, you will see that the upper maxilla is get smaller and the lower mandible is get larger. It's not smaller or larger, it's a pattern of resorption. And in each place we have extract, it's going for resorption. Sometimes resorption for the width, then it's going for resorption for the height, and you'll have this classification. So as there is this resorption of bone will affect the prosthetic options and the prosthetic space. If you have extracted the tooth and you will add an implant after 2 months or 1 month or 3 months, okay, this one you will see that you'll have just restore the crown, and this one in classification for the card mesh is called FP1. So what about you left it sometimes and you have some sort of cementum appear, okay, or some place of roots, this will have FP2. And what about if you have a lot of resorption and you have a gingival? And when you, as we all see after a while, when you make a bridge or something like that, and you have a larger crown, you make a big porcelain, so you restore some sort of gingival. This one is called FP3. Well, what about the complete denture? As classification for complete denture, yes, it's called RB4. It's removable prosthesis, but it have a lot of implants. It's 4 or 5 implants, and 4 or 5 implants. These 4 or 5 implants, you will have like an overdenture, or the implant or denture will be attached and removable by the patient itself, and this totally implant supported. What about the next? If you don't have any bone for this, you will have 2 implants in the canine region, canine lateral region. It is called overdenture, implant assisted overdenture, and you see that the mucosa and the implants is for support will gain from the mucosa and the implants, and it's called implant assisted prosthesis. The place for the implants for RB4 and the RB5, it will be discussed in another lecture. Where we put an implants. We put an implants in any place? No, it's some sort of places that will have favorable conditions for the support and the forces that's again on the bone. Okay, for the right side is FP1, FP2, FP3, and we said it's fixture. It's like sort of abutment, and this is a crown. In the other side, this is a denture. These are attachments that's good for denture for the implants, and the implants is the same way. The fixture is the same. The abutments changes for abutment to ball and socket, and the superstructure here crown, and here is denture or overdenture. So according to what we have, we are deal with the case. Okay. As we said, this again, this one is the implant itself, and this one is the abutment, and this one is the superstructure, right? So this one is get for the implant with the screw, and this one is cemented to the abutment itself. So like an even crown. So is there any other types of the prosthetic options? Yes. We have some called screw retained. What is the screw retained? The crown and the abutment is one unit, and the screw that engage the abutment to the implant, engage the crown itself. So it's called screw retained. So the normal way is two pieces for the prosthetic option, the implant, the abutment screwed in the implant, and then we'll have this crown cemented on it. And this one, no, it's not one. This is the abutment screwed in the implants, and the crown with the abutment is one unit. So this is called the screw abutment. This is for single, and this one for the complete dentures or complete prosthetic options, not dentures. Okay. As we said that we have FB1, FB2, FB3, and a lot of prosthetic options. So what we have different types of abutments, and we know that these abutments, this one is called abutment, this one all, this for the crown will be added, and this one, and you said this color for the gingiva, this one will be under the gingiva, and the gingiva will be here like this and like this, and this screw will be get in and screwed. This is all for the cement retained. And as we have FB1, FB2, FB3, we need to have a lens for this one, for the abutment, as this one will need 6 milli, and for the crown will be 3 or 4 milli, and this one will need more to be 7, and this one will need more to be 8, as we not increase the thickness of the crown. As increased thickness of ground, as you know, it have a lot of porosity and fracture strength and fatigue or something like that. So we have different here abutment lengths. Also we have different gingival former, as we know that some sort of implants that have some sort of patients, that have thick gingiva or gingiva that's thick. It's not thin, and some other have thin, so we need to make different type of abutments that have different gingival height. Also the material itself, some sort of peak and some sort of peak, like for aesthetics options. That's, as we said, that's aesthetic options, like if you have anterior teeth and we need to go for Emax, so we don't need to have metal underneath this one and to make a shadow or something like that, so we use peak or zirconia abutments, and we'll talk about that later. And the angulations, as we said, that the lower 6 or lower 5, it's straight to the mandible itself. It's going straight to the mandible and perpendicular to the bone. But if we have here an anterior teeth, as we said, that the bone is going like this one, and we'll have an implants, the implants will be going out. So we need an abutment that's re-angulate or correct the angulations to be with the posterior teeth, or with the lower teeth. So this one is called angulated abutments, and it have a range from 5 to 15 according to the case. So we need the angulated abutments, and we need the different type of materials. Okay, some sort of called hex. This one is like anti-rotational movement. The abutment will not go right and left, and some abutments will no need for this hex. So now we have the screw retained. How we do the screw retained? It's normal way. As we said, that the crown and the abutment is one unit, and the abutment and the crown will screwed in the implants by screw. So how you get that? How you get the screw implants? How we get the screw prosthesis? It's like the normal one. You will have a plastic one, and after we have a plastic abutment, we will add some sort of wax over this plastic abutment, and some sort of wax will be going to the invest, and after we go to the invest, and the wax will be removed, and we induct like some sort of metal, and we have this one, and we have metal, and we can make a normal person. This was in old days. Recently we have some sort of milling and some sort of tie base and some sort of different materials that make a screw retained easier and better than that. Okay, so why you use a screw retained? This is an indication to make a screw retained. Yes, we have a screw retained, and in parallelism we need have parallelism between two. If you have two implants and going for screw retained, we need parallelism between them. Okay, when we use screw tent, when the crown height space will be 8 milli. Why 8 milli? If you have the prosthetic crown space 8 milli, it's too short. We need to have a screw tent. Why? We don't have screw retained. To override, to make alveoplasty, to move bone, or to remove tooth. So why we use screw retained? Why you don't use like some sort of cement retained, the normal prosthetic options? As we know, that's some sort of series. It's called tipping pass. As if you have this one crown and this tooth is reduced, and you have force here. So what would prevent the crown to be going out in these directions? This wall. So when the wall increase, the friction increase, and the crown itself will be more retentive. But if you have short crown or divergent crown, this crown will lose of retention. So if you have crown height space with 8 milli, that will lead to some sort of less retention for this crown, and the crown will be moved or be non-retentive, and the cement will not go for it. Okay, so if you have crown space with short crown height space with 8 milli, go for screw retained, don't go for cement retained. Okay, what about FP3? FP3, as we said, that the crown height, the prosthetic option, this prosthetic option, it will be restore the crown itself and the gingiva. So if you have the crown and the gingiva, this one will be 10 millimeter to 15 millimeter. Okay, so if you have a huge one like this, go for screw retained, don't go for cement retained. As we know all that the cement retained for the manufacturer, for the cement retained or manufacturer of the crown, if you have a lot of metal and you have a huge type of metal, it will go for porosity, and if you have a huge type of porcelain, it will go for some sort of crack in porcelain. So we can go for screw retained. So there's two options for screw retained: too short crown height space or too long crown height space. You're going for these issues. Okay. What about RP4 and RP5? What about RP5 mainly, overdenture? We have a lot of attachments to it, para attachments, pole and socket, locator, and equator. This is the shape of the pole and socket, and equator. And according to the prosthetic space or inter-arch space, we're going to choose the type for the attachments. Okay, let's talk about ball and socket. Ball and socket, it's like a ball and there is a clip, it's plastic one, and this housing. And the clip will be added here in this undercut. It's like the clip for the clothes, as you see. If you have a white coat, you will have this clip. Okay, it's the same. This one for the nylon cap, it's like a flexible one that gets in here, open, and then engage this undercut. And when you remove it, when you have a force, it will be go up, and this one will be open. This is called ball and socket. The ball itself, it have a different height side, and the clip itself have different color to be different flexibility and different retention issues. And this for this one will be added on the implant and the screw on the implants, and you will have the nylon cap and the housing in the denture itself. This one, yes. Okay, when we use stud, when we have less space requirement, we have inter-arch or inter-prosthetic space and low vertical dimension. When we need different degree of retention, resilient, the cost it's low, and it's easy to be added. The main disadvantage is where the clip itself it need changes after a while. Okay, especially if you don't have parallel implants. What about locator? Locator without different shape. Okay, this one is rounded, and if we have this round and we remove the top, we'll get the locator. So the locator will be much shorter than the ball and socket. So if we have a case with low vertical dimension or small prosthetic options, so we are going for locator. Okay, so locator will have some sort of advantages on ball and socket, that it can be occupied less space under the denture. And as we said, there is a door retention. This one will be engaged here for the external undercut and engaged here for the internal undercut. This one will engage the internal undercut, this one, and the external one will engage this one. So it's called door retention. What about door retention? It's engaged inside and outside the locator. And this is the way that it's shorter than the ball and socket. As we said, the shorter will have less retention, but here we have different type of retention. We have door retention. We have retention inside and outside. In ball and socket, it's outside only. Also, it can be used as a self-alignment design, as it's low vertical dimension, and it's some sort of easy to be added for the inner side. What about the angulations? If the implant is angulated, so we go for 40 degree, we can go for this one, and the clip will be smooth inside. It will not have this undercut from side. So in flexibility for angulation, you're going for half door retention, you'll have single retention. So if you have angulated implants or divergent implants, and you will have low space, you can go for locator. What about equator? It's the same as locator, it's the same as ball and socket, but it's shorter and shorter. And if we see this one is locator, and this one is equator. The equator is shorter than locator, and the same. So if you have more and more and more and more, more and more and more and more vertical dimension with less vertical dimension, or interprostatic space is small, so we're going for equator. And as we see, this one, this is called the index. This index, as we see, there is the tooth, and this one for the flanges. So from this one we can choose or can know the height of the attachments that we need. So if you have like 4 or 5 mainly, so we are going for this for locator. If you have 6 or 7, we're going for ball and socket. If you have 3 or 2, you can go for locator. This is an example. So how we make this index? We will have try-in on the cast, and we'll make the dentation here, and then we are going to add rubber base, soft. Okay, and after a while we'll remove, after this one is harder, we'll remove this one, and will be added again on the cast. And remember that there is a notch here and here. This one will be set, and you will see here the tooth, and you will see the flanges. So now we are going to know this space, how much, and according to it we are going for choose these attachments. And also can use it as we need to know the length of the abutments what we need. The bar is get most probably with rounded, and some sort of called bar unit and bar joint. This rounded is resilient, and it's taken for RB5, and this one permit some sort of movement. This some sort of movement that's led that you have implant tissue supported. Okay, so this implant tissue supported, just you need movement, that the bone and the tissue will have some sort of support and some sort of force on it, and the implant itself will have some sort of one also support on it. Okay, and these are the shapes of the bar. This is called the spar unit. It's not permit movement. It's used for RB4. It's just split or splinting the implants itself with each other. There's some sort of the bar requirements. The bar must be parallel to the occlusal plane, perpendicular to the midline, and must be some sort of space between the bar and the tissue. That's for the bar unit that permit some sort of movement. This must be added. So if we see and if we think in that, we will have here space and here space for the bar and space for the flanges itself. So we need like a huge type of vertical dimension or prosthetic space. So if we have enough prosthetic space or vertical dimension, we can go for bar. If you have less, you can go for ball. If you have less and less, we're going for locator. If you have less and less and less, we're going for equator. So the bar needs a maximum vertical dimension. What's the advantage of the bar? It's blending of implants. So you have stress distribution, better retention, better muscular performance. It's difficult, need, as we said, a huge prosthetic space, and we have high vertical dimension, and we need some sort of technical skills. This one is housing, and the clip, as we said, this one will be in the denture itself. And this is a way to make this one the denture. It's called the pickup, and we can transfer it and say it in other issues. Arch form, as we have, arch form, it will be one of the terms that determine what you have a bar or pole or locator or equator besides the vertical dimension. So if you have like square shape here or V shape here, square shape here, if you put an implant here and implants here, you can connect it with a bar. But if you have V shape and you have one here and you have one here, if you have a bar, this means that the tongue will be deflected with this bar. So the tapered or V shape, it will have long cantilever and more forces, and will have the implant itself will be not good. So we're going to change from bar unit to bar joint, or we are going to change it from implant supported, the implant supported to implant supported, or we are going to change it, the treatment plan to be locator or equator or something like that. Well, what about RP5? RP5, it means that you have a denture. This denture have a lot of prosthetic space, and bar which not permit movement, and we'll add some sort of attachment on this bar, and we have a cantilever here, as we all know that is in the posterior area there is a nerve here, and some sort of terms that not required to put an implant in the posterior region. So we need here a cantilever. So we need a rule for this cantilever. The cantilever will be too much or too small or whatever. Some will add 5, some will add 6, some will add 5 and 6 and 7 tooth, some will add 5 and 6 and 8. So we need a rule to make this cantilever how long. The rule is simply that's called AP spread. What's AP spread? This AP spread is a line, the distance between the line for the anterior implants and the posterior implants. This is called AB. Okay, this AP will be multiplied by 1.5, and this will be the length of the cantilever. So if you have implants here, 4 implants, and I have this line, and we have posterior line, and I found this one is 10. So I can multiply it with 1.5, and I will find the cantilever length. Okay, this is called what? This is called cantilever. This is called the anteroposterior spread. That's the main rule to make this cantilever length. Let's have something. If we see 2, 4, 6 implants in the upper one, in the upper picture, and we have 5 implants in the lower picture, but we have here bigger AP spread than here. So what we need to know, that it's about distribution of the implants. It's not the main implants or the number of implants, it's the distribution of implants. If you have 2 posterior implants and 2 anterior implants, you can have a lot AP spread and you will have larger cantilever. Okay, and the arch form is also affected. This one is a tapered one, is have a larger base AB spread than a square one, and the V shape is has a larger. Okay, let's talk about something which is the main important one. It's called the prosthetic driven. The patient need an tooth, not need an implant. He need a tooth to eat, to have masticatory, to have aesthetics, and something like that. If you have a case like this, and we found that we have 6.42 widths of bone, so we can put an implant. We can put an implant for 3.4, okay, or 3.5. It will be good. So we'll have an implant here in the middle of the bone, like this one, okay, and
الحمد لله على السلامة.
ثلاثة كده بسرعة ثلاثة كده
في أي وجع، في أي حاجة مضايقاكي؟ ما كانش في أي حاجة مضايقاكي خالص ولا أي حاجة؟
This is my contact. Feel free for if you need to have some sort of question, as we said, or you have you need to have more information about any part of this presentation to make a separate lecture for it. Feel free to be contact. See you and thank you for your attention.